file with us all the money you collected in premium, and how much did you pay in claims in direct payments to providers, hospitals, doctors, durable medical equipment, pharmaceuticals, and so forth. That's the ratio we're going to look at. If you don't meet an 80% ratio, where 80 cents on the dollar was paid to providers, then you're required to provide a refund generally to your employer first. So New Jersey's had that law on the books. The federal law is a little bit, the calculation is a little bit different. It's kind of a messy relationship, but that same concept exists under the federal law. That was the mechanism under the law was designed to control costs and is seen as sort of a proxy of efficiency for the health plan. And then lastly, and you see this reflected in the federal law as well, is you had standardization of plans in New Jersey. We have about 35 mandates, so the state mandates that 35 things be covered. And then it also defined by regulation the plans that the insurance companies had to offer. So with that regulatory legislative structure, the standard plans, the idea was to make it easy for consumers to shop so that they can compare apples to apples. So it was Plan A, Plan B, Plan C, and it had different deductible options. That was the pre-ACA landscape, what we've had today in New Jersey. In terms of how well it's worked, one of the best metrics is to look at enrollment, right? So if you look at the individual market, I wish I had gone back in time, but I didn't have time to do that. If you look at the individual market, it started up, going up a little bit in the initial the rollout of the market. So it went up to about 220, 230,000 covered lives. And then really the rules around guarantee issuance, the pre-X rules, the rating rules made this market tank. It went down to 77,000 covered lives and was really in the trajectory to have a total market failure. In around 2002, 2003, the legislature passed a law that said, we're going to create a more modest benefit package that carriers can offer, where it's not going to be this very rich plan. And we're going to allow some rating factors to be age and gender and geography. And that product is known as Basic and Essential, or the B&E plan, rolled out in 2003. And then what we saw is that the nosedive down to 77,000 went back up, and now you see a steady increase since 2005, and it's up to about 143,000 covered lives in that month. So these are folks buying individually with their families. So out of 8.6 million people, this is not a big chunk of where folks in New Jersey get the coverage, but it's a significant, and that's going to be the area of growth under the exchanges. The small employer market was a little bit different, and that looks more like a bell curve. The reforms there were the market was more robust and able to handle the guarantee issuance and the rate compression rules. And you saw an increase in lives. It went from 690,000, I think, to its peak around 920,000 covered lives. But what happened in 2005 is that the rates really started to become difficult. And employers were getting, in the mid-90s, the rate increases were sort of flat or low with the introduction of managed care. But that was sort of a one-time savings, and you saw increasing rates that you don't have exit polls as to why folks are leaving, but a lot of this we think is the result of rates. So you went from 920,000 covered lives. It's gone down every single quarter. The Department of Insurance measures this since 2005, and it's down to 670,000 covered lives. That's over 250,000 covered lives dropping. So, if you were to sort of say, how did the market reforms do in New Jersey? I think you'd say a really tight rate compression guarantee issuance was not feasible in an individual market, and it's still an expensive and difficult market to operate. But allowing some rating flexibility did allow the market to avoid a crash and burn. The small employer market, it was really just about affordability, and the chief challenge that market has. The other thing I think is worth noting is that I think this is somewhat unique to New Jersey is special problems regarding out-of-network services. This is a chart that shows on the left the percentage of employers that purchase plans, PPO or point-of-service plans, with both in and out-of-network benefits. If your employer is lucky enough to be able to offer those, they tend to be more expensive. What we have seen over time is a drastic drop in the number of employers that can afford to offer plans with out-of-network services. So it was over 60% of them small employers offered out-of-network benefits. That's now down to a little over 30%. So it's a huge drop. Even if you buy what's called a closed panel HMO product, that doesn't traditionally cover out-of-network benefits, those plans still cover some out-of-network services in emergency situations. So even the employers that have purchased these plans with generally no out-of-network benefits, they're still subject to the problem in New Jersey around some of the pricing that we've seen with out-of-network hospitals especially. And I think the previous speakers had mentioned that the Bayonne Hospital was, as a result of the CMS data pull from hospitals, was the most expensive hospital in the country. So again, it's another key trend is the challenge of employers in purchasing out-of-network services. Okay, now to move forward here to the ACA, what do we expect to happen here, and what's happened so far? As Joel noted, the open enrollment period begins on October 1st. We've seen Secretary Sebelius say, asking the question, are you going to be up and ready to run? And she said, well, yes, there's no plan B. I would agree with Joel's assessment that this is going to be enormously challenging in the next few months to get this up and running by the state. But the plans have their nose to the grindstones trying to make this work, and it's going to be challenging. So open enrollment starts October 1st. The actual coverage period would begin on January 1st of 2014. And in the insurance exchanges, you have to offer what's known as a qualified health plan. Take a step back. I know Dr. O'Leary talked a little bit about this, but I was confused at first about what is an exchange exactly. Normally, when you go to buy coverage today, you go through an insurance producer or a broker or a licensed broker. And they'll give you different plan designs and say, well, here's a spreadsheet you can pick from Aetna or Cigna or United or whomever. That's how that's normal distribution system today. The idea of an exchange is to create an online portal for folks to shop and have a little bit different shopping experience with more information, quality metrics around the plans, information about their networks, information about their pricing. That would all be in an online experience, and there would be a no wrong door policy, which is as they're saying, so that if I'm a consumer and maybe I'm eligible for Medicaid, maybe I'm eligible for a subsidy, I'm a small employer, it's the right door from everybody. You're not going to be turned away and have to shop elsewhere for coverage. On the exchange would be sold only qualified health plans, which meet certain standards, and I'll talk a little bit about that. And there's two different exchanges. There's an individual market exchange and a small employer market exchange. The small employer market exchange is still for the up to 50 covered lives. The law requires it to expand to 100 lives in 2016, and then in 2017, states have the option to just open it up to all employers if they wish. I suspect New Jersey will not head down that path, but we'll have to wait and see. I guess the other key component here is that states were given the option to choose a federal model, a shared model with the federal government, or a federally facilitated exchange, or FFE, or federally facilitated marketplace. New Jersey chose to have, as most states did, to have a federally facilitated marketplace. So what is a qualified health plan? What are the elements of it? What has to take place? Again, part of the instinct or the impetus for the reform is to make sure that folks had substantial coverage. Prior to reform, you could have a plan, especially saw some really large employers with lower wage employees, you could have plans that really have very modest benefits. So the idea was to have some minimum level of benefits, and this is how they define it. First, it had to have 10 articulated essential health benefits, which is on my notes. It had to meet certain cost sharing requirements. So your deductible, co-insurance, your copay, your out-of-pocket maximum had to meet certain standards. There's actuarial value standards to help you shop around, and they have metallic branding to try to make it easier. So the bronze is 60% actuarial value, silver is 70, gold is 80, and platinum is 90. Think about this simply as if you look at a healthcare plan that has a 90% actuarial value, it would cover approximately 90% of the average person's cost for healthcare. And it would have to meet all state and federal guidelines. The essential health benefits, kind of the things that are in most plans today, ambulatory services, emergency services, hospitalization. This is not, there's not much here that's significantly different. Until you get to the last bullet, you can see pediatric oral and vision care. Most insurance plans have separate dental or vision plans that they do offer. It hasn't been incorporated into the major medical hospitalization plan concept. The Affordable Care Act will require these services for pediatric services. Orthodontia is going to, that's probably one of the bigger cost items that will be added here. So what people are buying on the market today compared to what they're going to be buying in the future is going to change, and they're really going to have to buy up in services, in part because of the pediatric oral vision here. And rather than with those 10 essential health benefits, the federal government could have prescribed the contracts that had to be offered in the country, but they wanted to transition a little bit better. So they said for 2014 and 2015, we're going to hand this decision off to the states. You can pick a plan from this menu of options that says, here's how we're going to sort of the model we're going to use to fill in what those benefits for those 10 essential health benefits look like. You can pick from your state health benefits products. You can pick from your standard small employer, or the most popular products in your small employer market, and so forth. There's 10 options from which they can choose. Governor Christie decided to pick the most popular small employer plan, which is what most states have chosen. So Horizon had the most popular plan in New Jersey, so that's sort of formed the benefits. So essential health benefits is sort of defined by that package. The problem that all states really had was like if the essential health benefits weren't part of that state selection, then you had to wrap those services around and define those in some fashion. So the governor chose the New Jersey Family Care Dental Package as the definition for how the dental services would be covered for the pediatric dental. And then the Federal Employees Program for Vision Coverage was chosen as the model for the vision coverage. So the Horizon plan plus those two plans really forms the basis for how essential health benefits have to be offered in New Jersey in 2014 and 2015. If you're going to get, Joel talked about the subsidy, I think that's related to, to make coverage affordable for lower income folks, there is a premium subsidy. They're only available if you buy on the exchange. So we've talked about the exchange. The exchange is really just one vehicle for obtaining coverage. You can still go off exchange and buy coverage from insurance carriers off the exchange for the small employer market, individual market. So it's not the only place that you're going to be able to shop for coverage. The premium tax subsidies were this idea that if you're going to have a mandate for coverage, it's unfair to do for folks who have lower income levels. So the law provided for a subsidy to help folks offer coverage. You have to buy on the exchange to be able to get that tax subsidy. It's not available off the subsidy. And just to give you a sense, I don't know if you see the slide in the back there, the subsidy goes eligible, individuals are eligible up to 400% of the federal poverty limit. For an individual, that's $43,320. For a family of four, that's $88,200. So as Dr. Lay pointed out, there are, New Jersey has selected Medicaid expansion, which is going to bring folks up to higher levels of income, and then the subsidies are going to be essentially available for folks at 100% to 400% of the federal poverty. I'm going to give you a slide that just gave you a sense of this. This is a sliding scale, so up to 133%, it's going to be the premium limit that you would pay would be 2% of your income. The state would look at that silver. It's the second most least expensive silver plan in the exchange would be the measuring stick for looking at your affordability limit. And you could get a subsidy, so you only had to pay 2% of your income if you're up to 133% of the federal poverty line. And as you see, as you go up in income levels, the subsidy goes down, so that you have to pay a larger portion of your coverage toward the premium. So that's not the only subsidy in the ACA. The second piece is cost-sharing subsidy. So your deductible, your copay, and your co-insurance, and your maximum amount of pocket is the piece after your premium contribution you pay. You also have these cost-sharing elements in a health insurance plan. For lower income folks, the cost-sharing elements would be a barrier to obtaining coverage in many cases. So there are out-of-pocket limits that there's, again, up to 400% of the federal poverty line. There are subsidies that are available, to help lower those caps. Mechanically, I have to confess, I'm not sure how this is going to be done at this point, but it's going to be difficult to provide these subsidies to folks. Just to give you a sense, here's the cost sharing subsidies under the federal health care law. I don't have a slide on this, but I did want to add this. The other element that is, I guess, in a way, a cost saver is that the federal government has a provision that deals with state mandates. I think the theory was that if the federal government was going to provide subsidies to folks to be able to get coverage, they didn't want states tacking on a number of laws to make coverage very expensive and say, well, we're going to mandate coverage for X, and we're going to mandate coverage for Y, because the federal government's going to subsidize that. So the the ACA has a provision that says that states are going to be required to defray the cost of those new mandates. There's some regulatory guidance out on this, and that as of any mandate enacted after 1/1/2012, the state treasury is actually going to have to defray the cost of that new mandate. So the legislature right now is looking at a number of mandates. There's probably 30, 40 mandate bills out there, a couple of them through the legislative process. To the extent that they are for coverage on the exchange, it's going to be a straight treasury cost to pay for those mandates. There's a recent it's a message we try to get across, and I know the fiscal notes have started to include this. They don't know how it's going to be measured yet. So they haven't measured that on some of the mandate bills that have been proposed. But it's an important component because there will be this offset from state treasury to the federal government, or to the plans. Those are the elements that are going to help to try to bring costs down and make it more affordable and accessible for consumers. And as Joel noted, there's also some countervailing, called a whipsaw or a seesaw. There's also elements that are going to make coverage more expensive and more challenging to obtain. The first I wanted to mention is the ACA premium tax. There's a number of different taxes on different industries. The one on the insurance industry is, there's some, Oliver Wyman did a study, and it's estimated to raise $5 billion over 10 years in New Jersey. So the taxes for periods of 2014 and goes on, that 10-year period starting 2014, the hit to New Jersey will be $5 billion. It's an excise tax on the health plans based on premium. But as the CBO has noted, insurance companies, like most businesses, are likely to transfer most of that onto the cost of the service. So that's about $500 million a year in taxes. I've seen actuaries rate this at somewhere between 2 and 3% of premium in addition to the premium to help offset the cost of this tax. The tax goes up over time, so it probably will start with less than $500 million. It's just on insured business too, I should say. So it's on insured business, it's on Medicare Advantage plans, it's on Medicaid plans. It does not apply to self-funded plans. So you may see some, right now you see a lot of employers giving a new look to self-funding benefits, and it's becoming a more and more attractive option, in part because the taxes are not borne by that kind of coverage. So the employers who are on the ledge between, do I insure, do I self-fund, can I assume this level of risk? Is that, the more and more the insurance costs go up, and the more mandates there are, I think you'll see self-funded coverage become more and more attractive. There's a number of other different fees and taxes that are going to find its way into the premium. There's a comparative effectiveness fee of $1 for the average number of covered lives that goes up to $2. There's a 3-year reinsurance fee. It's kind of complicated, but think of it as a group to individual market transfer to try to make the individual market more affordable. It's significant though. It's $5.25 per member per month for those 3 years. And then you also have a surcharge on business sold through the exchange under the federal law at 10.5%. So just looking at all these different taxes and fees, in addition to the normal trend that you'll see, in addition to the benefit increases in these taxes, we've been trying to make sure that folks are cognizant of the implications on cost, because we do think the cost will be adversely affected. Just a note on that surcharge. New Jersey's had a number of plans that have filed